Hello, good afternoon. Thank you for attending this webinar. It will be a webinar series that will talk about tips for incoming interns and how to succeed in residency. And we will have outstanding speaker today. Let me start by introducing myself. My name is Omar Saab. I'm one of the assistant professor at the University of Texas at Houston, and I'm attending physician and the Hospital Medicine Division in Memorial Hermann Texas Medical Center. And just to give a heads up that this webinar will be recorded and I will share it on my YouTube channel for other people to learn and have access to it at any time. We have to make sure that our talk is based on our experiences. We do not represent our institutions that we are working at, and we don't have any sponsoring institution or agency. We did not receive any financial benefits from this webinar. It's completely free and voluntary. Our goal is to help our colleagues to perform well during their residency and take care of themselves. It is really important to hear from people who already went through this journey before you. We don't have any financial disclosures. We don't have any conflict of interest. Uh, I will pass this message to Dr. Al-Judi. She will be a moderator, and we both will moderate this webinar, and then she will introduce Dr. Al-Ani, and then Dr. Al-Ani start her presentation, and we will keep the questions at the end. Please write your questions in the Q&A section, and we will try to go over these questions at the end. Thank you very much. Dr. Al-Gudi, you can go ahead.
Thank you, Dr. Saab. My name is Marwal Judy. I'm one of the incoming preliminary internal medicine interns at Hackensack Meridian Health, Jersey Shore University Medical Center. I will be one of the moderators. Now, I'd like to welcome Dr. Hayal Ani. We are more than happy to have a great presenter today. Dr. Al-Ani, who is a PGY1 internal medicine resident at Mayo Clinic, Arizona. She completed her medical school at the University of Arizona College of Medicine in Phoenix. Dr. Al-Ani is always motivated to help the community, especially the medical community. Her experience in such a great institution definitely will make her an outstanding person to talk. Tips for incoming interns and how to succeed in residency. Welcome again, Dr. Al-Ani, and thank you for accepting the invitation to give this important talk.
Thank you so much, Dr. Judy, and thank you, Dr. Saab, for having me today. Good afternoon, everyone. Welcome to this webinar, and congratulations. This is so big, and I'm excited for you all. I'm going to go ahead and share my slides. However, I want this to be as conversational as possible because, like Dr. Saab said, this is all about personal experience, and like he shared, this does not necessarily or does not represent my institution or endorsed by my institution, whether it's Mayo Clinic or University of Arizona. So my presentation will be centered around how to thrive in residency. Now, let me try to see if I can toggle through this presentation. All right. Can you guys see my screen? Right. So how to thrive, I'm going to divide my presentation into two categories, personal life tips and professional life tips. Intern year is so busy, you're going to hear different opinions. In the end, you're going to hear things from me, things from other people, other esteemed colleagues. And in the end, it's all about your personal style and how you want to move forward. Excuse me. So a little bit about professional life. Overall picture is, yes, intern year is going to sound chaotic on day one. I still remember my first day. I didn't know how the day went by. Without my senior, I would have probably not survived that day, honestly. But moving on and moving forward, you start to develop your routine. And the routine I share with you here on this slide is specific to hospital internal medicine because this is where I'm coming from. Realizing that you guys come from different backgrounds, maybe some of you are doing other things, but just from conversing to other colleagues on day-to-day basis, this is basically Shared between specialties. So my goal is to, from this presentation, really is to tell you the endpoint is to have your routine because routine goes a long way. Um, make you more organized and make you less susceptible to making mistakes. And this is, the development of how many months now? I would want to say 10 months of doing internship. So it's not going to happen on day one. So after 10 months of internship, many months of inpatient rotations, I developed my routine. And this is something to make sure that you are taking full ownership of your patient because you are their doctor. Don't let anyone tell you you're just the intern. And honestly, something I noticed from rotating previously as a medical student in a different hospital, which I didn't like, is when interns are addressed by their first name, by staff especially. This takes away your authority. You do have the authority, you do have your degree, you do have your temporary license, which is going to be permanent at some point. You do have that trust from the community to treat people. So don't let anyone tell you you're not taking care of that patient. You own the care of that patient. And to fulfill and deliver this responsibility, um, you want to make sure you cover all aspects of their care, especially when it comes to hospital internal medicine, because we are the captain of the ship. So anytime in the morning, you go to the patient charts, you want to check the first thing you want to check about them is their vital signs. Anytime you get a call about a patient, you want to check their vital signs because you want to know how this patient is doing. Are they hemodynamically stable? Can you take your time to investigate and see what's going on with them? Think a little bit about their problem, or is it something that you need to leave everything behind and go and see the patient right away? So this is my routine. Again, this is my style. You feel free to develop your own style, but I check their vital signs, their labs from overnight. Micro goes a long way. It is something that I personally tend to forget all the time. If we gotten some blood cultures days before, and then all of a sudden it grows something, we want to know about it. Images, because sometimes, yes, your night colleagues fail to communicate to you. Not that it happened to me personally, but it happens. They don't tell you, oh, patient developed shortness of breath and we got chest x-ray. And now, like, there's something on the x-ray. The ins and outs, you want to know their volume status and their bowel movement. This is a big thing for internists, for internal medicine. When people don't go, then there's a problem. Always something I personally forgot and gotten in trouble for is how many lines they have. Do they have a peripheral IV? Do they have a central line? How old it is? Sometimes infections and things can happen from lines. And if they're on any drips, respiratory status. Um, if they're like on any supplemental oxygen, what kind of supplemental oxygen they're on. Overnight nursing notes. This goes a long way. So as a medical student, I only had two patients to see every day. So I would have time to go and chat with the nurses and tell them, hey, what happened with the patient overnight? And they will tell you everything because nurses know everything. But as an intern, you do have 6 to 8 patients, depending on your institution. And then you don't really have a time to sit down and chat with each nurse for 10 minutes. So, but they drop their overnight note when they change the shift. Most institutions do that. So reference this note, it goes a long way. And something I got in trouble for definitely before is forgetting what medications my patients are on. You don't need to jot down every time, every morning when you chart checking what every single medication they're taking. But some important medications, especially those that have an effect on the hemodynamic status, and especially if it's something that is gonna require other things down the line, like being on steroids. So I just bombarded you guys with a lot of information, a lot of details, and we had just started the presentation. But the moral of this slide is develop your own routine. For any specialty, really, and for internal medicine, it goes a long way to have a paper, a pen and paper every morning with you. You will hear different styles and different things from people, but at the end of the day, have a to-do list, something you can scratch off and keep track of your daily tasks because it can get really daunting at the end of the day if you forget that you needed to order chest X-ray for your patients, and then 2 3 hours later, your attending asks you, "Hey, did the chest X-ray result come back?" It's not a good look. Your senior, especially in the first few months, is going to be there for you. Seniors usually do enter the orders, but I highly advise that you treat it as if your senior is not ordering anything. And I want you to go and double check that the orders went in actually. Most likely, you're going to be working with PGY3s on your first month, so they'll be experts, but still, just get in the habit of owning your patient, making sure that all the orders are in. Definitely, rounds differ from different like, institutions and between different attendings. Rounds, internal medicine is infamous for having long rounds. People are sometimes moving away from that and doing table rounds. But after rounds, I want you to have your to-do list and a way, maybe like a red marker or pen to highlight the important tasks that you need to do first. I think for internal medicine, the most important thing is to make sure that you call the consults as early as possible. So chart checking in the morning, time yourself, see how much time you'll be taking. Let me tell you, even after 10 months of doing internship and increased efficiency, your first day on inpatient medicine, you're going to take a lot of time to chart check patients because these are people you don't know. So give yourself the grace, give yourself the time, and please don't freak out that you're taking a lot of time to chart check each patient. You'll be doing fantastic. On the outpatient side, outpatient can be confusing because depending on the specialty versus your own clinic, um, you'll have a different relationship with the patient. So if you're working, let's say, in hematology clinic and you're seeing patients, you're not seeing your own patients, you're seeing that attending's patients. And it sounds a little bit, I want to say, weird in a sense that there is a continuity of care between that attending and the patient, and then you're coming in the middle and you don't know anything. So in the beginning of the year, sometimes it takes a lot of time and unfortunately it takes some time of your personal life, and I don't want that to happen. You just have to allocate maybe an hour, like the night before you go to clinic, and just skim through the patient chart in your head or like have a sticky note that says this is their biggest problem. It helps to know a little bit about the patient before you go in the morning and see them with the attending. Um, Sometimes in clinics, what happened to me, I happened to rotate at the VA, and the VA is a different place from Mayo Clinic. In Mayo, we have a lot of time to see the patient, staff will be attending, write the note, then see the next patient. At the VA, you have 20 minutes, and these 20 minutes, you got to see the patient, staff will be attending, go back. So I never really had time to sit down and write a note. If you find yourself in a time crunch and you don't have the time to write the note, I would highly recommend that after the encounter, you just sketch the assessment and plan, just like very simple, very basic. This is a problem. This is what we're doing for. Because after when you're taking your lunch hour and you're trying to get caught up on the notes, you're going to feel like, oh, I forgot what we discussed with this patient. I forgot what we were doing for them. So the outpatient TS is going to feel a little bit off-putting, especially if it's not your patient. In your continuity clinic, you'll have much more fun. Continuity clinic, to me, is a place where I developed more efficiency and better ability to communicate with patients and build that rapport. Um, Something also helpful that I found from working with attendings and in specialty clinics like cardiology is asking them at the beginning of the day, hey, doctor so and so, how many patients do you, not how many patients, but what patients do you want me to see today? Sometimes they will, like I said, they will give you the schedule ahead of the time and you'll be able to chart check patients the day before. But sometimes you will get the schedule the day off and you have to just, skim through in like 2 3 minutes, which is doable if you go to the latest note from the attending. So this is a lot of details. Forgive me for like starting right off the bat, but I think this is the meat of the presentation is developing your routine, having a checklist, making sure that you go down your checklist so you don't miss anything. This is just an example of calling consults. I remember as a medical student, it was really scary to call consults, especially with all love and appreciation. I say that surgical consults because surgeons are busy and they can sound angry on the phone. So it helps to have your question right away depending on how you call people at your institution. If you are still paging them or you send them a secure message through the EMR, you want to begin with a brief description of your question. For example, if you have a GI bleed, you don't want to call the consult and be like, hey, I have an 81-year-old lady who has COPD, who is presenting with acute hypoxic respiratory failure. They're going to be bored and you're going to lose their attention right away. When they pick up the phone, you say, hey, thank you so much for returning my page. I have a question about, I think this patient needs an emergent or urgent EGD. So their ears will perk up and they'll be listening to you. And then always offer the MRN or a way for them to open the chart. And then when they're out of the patient chart, then you can say, well, this lady comes in with like anemia and we're worried about GI bleed and we're going to and for gastroenterologists, maybe Dr. Saab will endorse that. They want you to do some sort of testing before calling them right away, like fecal occult, blood, or something of the sort. And then if you've done any of these tests, mention them right away, like, hey, we entertained these possibilities and we did this workup, and now we need your help with this specific thing. So always make your consult direct and start off with a question and be confident. I really do hope that you're as lucky as I was and get to work with attendings who are supportive and understanding, who understand that you're an intern and you're starting off the year and you're going to sound a little bit nervous and shaky over the phone and they're going to support you. But most of the time, when you're calling other services, you're calling actually another resident, another intern who's holding the pager. And in the end, of course, it goes a long way to say thank you. If you are on a consult service and you're receiving consults, it is totally normal to not know what's going on. It's totally normal to gather information and say, I will reconvene with the team and get back to you. This happens all the time. So please don't feel bad if you're on neurology and they ask you about this patient and you don't know what's going on. Please don't feel bad that you can't give them advice. Actually, most of these services the attending prefer that you gather the information, talk about the consult before giving any recommendations. Now, another thing about professional life, something that I would say harmed me in the beginning, and then I learned to get over is not being too concerned with feedback, because you will hear from people that, oh, feedback doesn't matter in residency and you move on and you move forward. And then as an intern, you're just focusing on doing what's right for your patient, which is, the appropriate thing to do. But honestly, feedbacks are important for two things. It's for your own professional growth, and it's also important because this is the program's measure for you to proceed to the next PGY level. So things I learned from personal experience is to ask the attending on day one. Um, you want to ask it in a way that shows you're interested in growing, not interested in getting a higher number on your evaluation. So first day on service with that attending, say, hey, Dr. So and so, I am working on this X, Y, and Z skill. Like I'm working on my interviewing skills, I'm working on my presentation skills, I'm working on my assessment plan skills. Can I please ask your feedback throughout? And they love it. If you put anyone in a mentorship position, they truly, truly appreciate it. And you become their student and they take good care of you. Also, another thing that I've noticed between attending is expectations vary. And something that can catch you off guard is when you get an evaluation and you see an attending saying, oh, I expected you to do this and this, but you didn't do it. And you didn't know this expectation existed. No one told you about it. So during that first meeting with the attending on the first day, just like 5 minutes, talk to the attending, tell them, hey, I want your feedback. And then also, Dr. So-and-so, what is your expectation for the interns? What do you want me to do? This way, you hold them accountable to what they're going to say in your evaluation, but also the measures you're working against or working towards actually. The ITE, the in training examination, this is also coming from a bias. You don't need to study for it, but it helps to skim through just the days before. And it truly doesn't, it's not going to change your life if you don't do well on the ITE, because who is going to do well on a board exam that you're expected to take at the end of your training, really? That defeats the purpose of training, right? But it is something that is important, and it's something they're going to look at and measure moving forward when you take it the second year. So it's going to be first year you do a certain way, and then second year they compare how you did the first year. So when I say do study for ITE, it's basically not for the first ITE. To clarify, the first ITE is just your baseline. You're coming off medical school or like before residency, however your journey was. So this is just your baseline. And then afterwards, throughout your intern year, while you're studying for step 3, because that's something that you have to take if you haven't, also make sure that here and there you're doing some board specific questions. Um, because the second year when you take it, and this is something I learned from colleagues, second year matters. How your performance during second year matters. So that's something you have to worry about during the first 6 months of intern year, but something to keep in mind. Like, I know life gets busy, intern year gets busy, but doing just 5 questions every other day goes a long way, really. Now, personal life. I can't emphasize this enough. Sleep. Please do sleep. I am someone who sacrificed sleep during the first few months of intern year in hopes of doing more. I wanted to spend more time with my family. I just happened to be someone who was front loaded with inpatient rotations back to back. So I would have to wake up at like say 4 a.m. every day and go to work. And just the way our system works is like we sign out 5, and so I'm home at 6. In short, every night, because I wanted to go home and spend time with my family or go out or do things, I ended up sleeping for 4 hours for 3 months. Now, do I need to tell you what happened at the end? I burnt out. And I don't say this lightly. Burnt out is a big word. And I did burn out because I started, so my burnout became manifested its self in being more stressed out, more sad, really, lacking insight on life. But also, I became more forgetful. So when I was doing my night rotation in January, I would do an admission order and I forget to hit sign on the orders. And that's big because that delays care for my patient. And that became a problem. And then when I sat down with my faculty member, she said, "Hey, how many hours do you sleep per night or every day?" I said 4 hours. She said, "This is catastrophic. This is not sustainable. You got to sleep 7 hours, at least 7 to 8 hours." Um, so it took a little bit of adjustment. So I became a cautionary tale for you guys. And after sleeping, we'll focus on my sleep, sleeping 7 to 8 hours. It works like magic. You become a totally different person. Yes, you're going to be missing out on life. You're going to be missing people's birthdays, and you're going to be missing your family's gatherings and outings, but it's all temporary, and people who love you will stick by your side and will understand what you're going through. Something else I use excessively is Google Calendar. You're going to have your personal life on the side, things that you're taking care of, especially if you have family and you have kids. So you have all these appointments happening, but also all these admin tasks that the program wants from you, all these meetings and things and the deadlines. It's hard to keep track of them. I value people's methods of using journaling or a book or notes. But the reason why I wanted to bring this specific example, Google Calendar, it fits any phone system, and it sends you push notifications. So you can put a task on it, or you can put a meeting time, and it reminds you, and you can program it to remind you the day before. So it really goes a long way because it's easy to forget things. And have you some me time? And I know for people who have a lot of life responsibilities, it's kind of hard. So my me time, for example, became my commute time. So I have to drive for 25 to 50 minutes every day. And that's a lot of time to spend on myself. And to also listen to do something that makes me happy outside of medicine. So I started listening to podcasts, not educational podcasts, but life related podcasts or listening to audiobooks and things like that. So having your me time goes a long way. And also quality friends. Don't feel obligated to make a lot of friends during residency. But find your niche, find the people who will be there when you need them. Um, you, internship year can be flavored with different flavors. People go through ups and downs, and it helps to have a community of people you can share your experience with, talk about your frustrations, and see that you're not alone in the process. I gotta say also, when you do that, be careful because um, you also want to maintain a good reputation about yourself, being someone who um, has it all figured out and someone who has it all together. And sometimes venting out to the wrong person can distort this reputation, if you know what I'm saying. So these are some of the lessons I learned. I know I shared some with you already, but submit admin work on time. I One of the rotations I had, which was a VA rotation, it's very demanding. There's a lot of paperwork that goes with it, and I ended up turning in my paperwork late. But that becomes a black dot on your record, especially when it comes to professionalism. So submit admin work on time, solicit feedback. I mention it again because it makes all the difference. And plan your vacations. Something else that also contributed to my burnout phase is that I stacked all my vacations towards the second half of the year. I thought this was smarter. But no, do plan your vacations, spread them out throughout the year. If you observe Ramadan, for example, be mindful of that. Maybe get like a vacation week during Ramadan and Eid. If you have research time, I highly recommend considering doing your research time during Ramadan. And don't say yes because in residency you'll have many opportunities. It's so much easier to actually thrive professionally in residency because doors are already open for you. People want you to do research. People want you to assume leadership opportunities. You no longer have to hunt for these things. People are pursuing you. So it becomes really enticing to say, yes, I want to sign up for this, I want to sign up for that. But just be careful. Don't put too much on your plate that you can't eat. And last phrase is given to me by one amazing attending with whom I worked a couple weeks ago. He said, "Don't think alone, especially when you're taking care of patients, when you're on nights." One of the mistakes I made when I was on nights is we had a really sick patient, septic shock, and I tried to figure it out on my own, thinking that this way I will impress my attending and my senior, and it doesn't go well. Always have loop people and bringing people with you on the ship, bring attending seniors, ask for help. So don't think alone, my friends. That is the end of my presentation. Thank you so much for listening to everything I had to share with you. And now I think it's a good time to answer your questions and see what you guys have on mind.
Thank you, Dr. Lani, for this amazing presentation. So I have a question for you, if you don't mind. How you build a good work relationship with your senior resident, and what are your tips for an excellent communication with your senior about your patients?
Yeah, that's a really good question. You'll find your seniors being close to you in training. You'll find it so easy to build that good relationship with them. Also, keeping in mind that people have different personalities. So if you happen to work with someone and you find that you're not building that connection, don't feel bad. It doesn't necessarily fall on you. Now, to answer your question, how to build that connection with your senior. Acknowledge their senior role. So on day one, also something I implemented later, I told my senior, hey, I made these mistakes in the past, or these are the areas that I want to work on. I'm gonna need your leadership and your guidance. And so just set the expectation with them. Now, for communication with your senior, it is very expected, very, very expected. Don't feel bad that at the beginning of your intern year, you're going to be communicating with them all the time, asking them questions like, hey, how do I replace potassium for this patient? Um, so that is okay. Methods of communication is also something you can address on day one with your senior, because you'll be spending 4 weeks with them at a time. So day one, say, hey, do you want me to text you, or do you want me to secure message you? Do you want me to page you? I think maybe 100% of the time, really, not even 99%, they will share their phone number with you and you can text them. Um, and and then moving on and moving forward, second half of the intern year, you'll be doing things on your own without telling your senior. However, anytime there's like a significant or alarming test result, anytime there's a significant or alarming imaging findings, there's like a patient getting sicker, like a call from a nurse saying like, hey, your patient's map dropped to 50s, let your senior know. I think one mistake we all make is trying to be independent and move away from our seniors, and seniors don't appreciate that. They are seniors for a reason. So always keep them updated. But in the beginning of the year, you're gonna talk to them about trivial things like electrolyte replacement. Towards the end of the year, you'll be talking to them about like important updates, needs to change the plan. So never change the plan or give a new medication or talk to a new consultant without telling your senior. So just a mutual respect relationship, acknowledging their leadership role, asking for their help. I think it goes a long way.
That's great. Thank you for explaining. So keep it open, keep it simple. Communication is important. And
Mhm.
all right. So I have here a couple of questions for you from the attendees. One of them asking any recommendations or writing notes about how to structure them.
Yeah, that's a really good questions, and I feel like it is a big sort of worry for most interns, myself included, at the beginning of the year. So notes, I'll be happy to share with you a sketch later. The most important part of the note is the assessment and plan, and this is the part that everyone reads. Your subjective part, whether it's the HPI or the daily subjective, is less important, but we'll talk more about it. Your assessment and plan part, this is coming from an internal medicine mind. Um, Group problems by organ system. Uh, and this is something you will be doing in the ICU a lot. Although in the ICU there's a lot of redundancy, I don't like their notes, but for internal medicine services, group them by organ, group them by or put the most prominent problem first. So, for example, you're having someone coming in with acute hypoxic respiratory failure. They didn't have oxygen. Now they need 2 liters of oxygen, even if it's just 2 liters. You address that problem, but also there's someone who have a COPD, history of COPD. So you put it under in the same group, COPD. There's someone who were a heavy smoker, so you put it under that. There's someone who's also coming with pneumonia, and that's actually the cause of their respiratory failure. So you put pneumonia. You group them by organ system. Now, something I started doing is, especially for these complicated patients who have a lot of history, a lot of workup done on the outside, is under the problem, under the group of problems, I put first, header is history. So in terms of like previous workup on the outside, if you have access to other EMRs or other labs or tests done outside of your hospital, you'll be able to incorporate that. Like for example, for this patient with COPD, like for example, last chest X-ray from previous hospitalization in January 2025 showed this and this and that, or like just the relevant things, not everything. So first thing is like past workup, and then current workup during this hospitalization. and then previous treatments, what treatments they were on previously, and then current treatments, and then the plan, your plan, what you're doing for them. But again, you will find different styles. People do it different ways. Something that you will also start to develop automatically, I actually see it in myself and other people through intern year, is that you will be writing your progress note every day with a hospital course in mind because you'll be doing, if you're on internal medicine, you'll be doing the discharge summaries. And this becomes daunting if you don't have the hospital course and if it's someone who's been in the hospital for 17 days. So for every problem list, it helps as you see the patient day in and day out to have a little part under the problem that is more descriptive, more narrative of their hospital course. Something that goes like on day one, they required 2 liters of oxygen. We started them on antibiotic. At night, the respiratory status got worse. They switched to high flow nasal cannula. We talked to ICU, but the patient didn't go out, end up going to ICU, and then started improving gradually, and then went off of oxygen. Just like a description, a narrative that you can later on copy paste to your hospital course when you do the discharge. Now, the subjective part of thing, it also varies between services. Let me tell you, as someone who's interested in hematology oncology, I work with oncologists, and in their HPI, they don't do subjective. They put all kinds of objective data. And this is a pet peeve to a lot of attendings, especially generalists like internal medicine. The HPI or the subjective part should be only what the patient tells you. And it just goes back to the basics. Like, for example, you're seeing this patient with a cough. You want to address each symptom separately. Like, when did the cough start? Is it getting better or worse? What other symptoms associated with the cough? Is there like fever? Is there sputum? Like, everything that is related to cough is in one paragraph. And then if they also happen to come with, I don't know, like volume overload or edema. Well, when did all this start? Do they take anything for it? So the subjective part is everything the patient tells you, but patients can get really tangential and go all over the place. It's your job to organize it and do, well, this is a cough, and this is everything they told me about the cough, and this is a edema, and this is everything they told me about it. And you don't need to say, oh, they had lab work on X and Y and Z date, and it showed that. This is objective data. This is supposed to go in the assessment and plan. But, just heads up, some services put all kinds of objective data in the HPI. I hope this was, helpful. I know you'll see different styles in writing notes, but just keeping things organized, keeping the hospital course in mind goes a long way.
Thank you very much, Dr. Amani. That was very detailed answer. Appreciate it. So there's another question for you. How to improve case presentation? It's also one from the attendees.
Yeah, thank you for the question. The case presentation, always stick to the basics. And when you're presenting your patient, have your paper in front of you. With time, trust me, you'll be doing presentations off the paper, but have a structure, a clear structure in mind. Um, Start, for example, you're doing an admission, you're presenting to your attending the admission, do a one-liner. This is a so-and-so gentleman with past medical history of this and this who's presenting with chief complaint. Now, different attendings again have different styles. Some people will tell me what happened in the ED and until they got admitted. And some people want you to do the subjective part. Now, the classic thing to do, the traditional thing to do is do the subjective part. And you say, subjectively, this is what they told me. And then moving on, objective data, when I saw them, the vital signs were this and this and that. Their labs were significant for this. Their images were significant for this. And moving on to physical exam. On physical exam, also pertinent positive, pertinent negatives, and then assessment and plan. Now, in the beginning, they expect you to do the one-liner again. Some attendings want you to skip and just do the problem list. But when you do the assessment and plan, do them by problem. For the cough, we're gonna do this and this and that. For the edema, we're going to do this and this and that. Now, when you're admitting patient, I forgot to say this. When you go to the assessment and plan part, you do the one-liner. You say in the ED on presentation, they were hemodynamically stable, afebrile, like just, their vital signs. Labs were notable for this. They were giving, ceftriaxone, a dose of ceftriaxone and liter of fluids. Just say what was done in the ED and then move on to your plan. Now, whether you do this part in the beginning or the end, the gist of the answer is to always have a structure, always follow the same structure, and this way you'll find later on that your thoughts are organized on their own. Another thing that goes also a long way, and I'll give you guys some tips and take it with a grain of salt too, because we don't want to put our faith and trust in AI just yet. Um, when you go and present a patient and talk about problems, have a plan in mind. Have already have a plan, have a differential diagnosis. It's difficult to do, especially when we're still learning and we don't have all the medical knowledge just yet, but have something to share with the attending. Say, um, for the cough, I have this differential diagnosis. It can be either viral or like infectious, either viral, bacterial, or it could be, I don't know, malignancy or like COPD exacerbation. Like just have categories of things. And the reason I brought up AI is because sometimes I found my senior doing that. We go to open evidence, which is now actually give you credit for CME, continued medical education, and you say, "Hey, just help me for headache. Like, what is the differential diagnosis? What can I think about?" Again, take it with a grain of salt. It has a lot of mistakes, but just something to help you when you're presenting to have a plan, to have a differential. It goes a long way. It shows that you're actively thinking. Yeah.
Okay, so have one liner, have differential, have a plan, and go share them with the attending. That's very great answer. Thank you for it.
Thank you.
So yeah, there is here one really interesting question. I feel like it also explains what's in my mind also. What was something that you wish you did before starting intern year, other than rest, of course? Basically, what can we do to ease the transition? Well, I want to say for the attendee who asked that question, thank you.
Honestly, I know you said besides rest, but I wish I had traveled. It just didn't happen that I got a chance to travel. But to prepare for intern year, everything you learn on the job. I know this is a no answer, but really there isn't something specific that you will do that will make you perform better. Um, Maybe if you want, you can do well, this is a long shot. This is an 100% an overkill, not a recommendation, but if you feel like your soul is burning and you got to do something, if you do, what is it called? The step three resource, the case, something case files or case something. It's stimulated cases or simulated cases, sorry. Simulated cases you also find in New World. The only reason I bring it up is because it gives you a patient presentation and it asks you to um, order like workup and lab. So it's an exercise to help you think about the things that you need to do for your patients when they present with this specific chief complaint. It's an overkill. I really would rather choose that you go on a trip than doing this, but this can be something that quiet, your nerves if you're stressed out. Um, and really, you know, to me, I feel like I learn by watching videos. So, and if you feel like you learn by watching videos, listening to audios, or reading books, if you feel like there's this subject that you're so uncertain about and you don't have a lot of medical knowledge on, which is, by the way, natural for all of us, you feel like you want to do something, just do like no more than a couple hours reading before starting intern year. And maybe, just maybe now I'm thinking about it out loud, just think of basic steps to take or basic workup to do for the most common presentations. Some of the most common presentations you'll have is chest pain, headaches, infectious symptoms. If your soul is burning and you want to do something, just learn in your head or very quickly, or even ask ChatGPT or OpenAI, like, hey, give me the most common presentations that people come with to the hospital and the most basic or initial steps to do. But really, everything else you learn on the job and prioritize your guys' rest and well being.
Well, that's great. Thank you very much for answering that question. So one last question we're gonna take. So there's also one here saying that I think there's a new program. No senior residents are going to be with them. So any
Mhm.
tips for that situation?
Yeah, that's tough. Well, congratulations on being the first class of residents. You're going to set the bar so high for your upcoming classes. In this case, just sharing from experience working directly with the attending, because even if you're in a program that has a senior, you'll happen to be with the attending alone sometimes when your senior takes a day off. So in this case, it helps tremendously to build a strong and trustful relationship with your attending. On day one, say, "Hey, Dr. So and So, what are the expectations? How can I reach out to you if I have an emergent question?" And just be comfortable with bugging them. Really, like what I told you from my experience, it's better to ask questions and bring people on board than thinking that you can do it on your own and failing to take good care of the patient. So, build a strong connection with your attending, acknowledge their leadership role, set the expectations with them, and keep a channel of constant communication.
Okay, great. Thank you for answering that question. So I just noticed there are also some questions on the chat. I was only paying attention to the Q&A. Yeah, one of them is asking about ICU rotation. If you can talk briefly about it, and after this, we will hopefully end this session.
All right. Yeah. Thank you for bringing up ICU. So ICU is difficult for everyone because the patients are complex. Things can go haywire in a split of a second, but just feel assured that most programs, depending on where you're doing your rotation, you have layers of protection. You have the attending, you have the fellow, and you have a senior resident most of the time. So there's like three, four people above you who are there to take care of the patient. Right, sorry, I had a technical difficulty. I was hearing myself. So yeah, with ICU patients, hopefully they give you a lower patient load. So this way you know to spend more time on each patient, go by organ system. Every day you go and see the patient, say how the end question, and this actually goes for all patients, is how can I transition them to the next level of care? For my hospital internal medicine patients, is how can I get them out of the hospital? What are the things that I need to do to get them out of the hospital? This goes a long way when you present your patient every day to your attending, because in their head they want to see if you understand what's keeping the patient here in the hospital and what we can do to help them get out of the hospital, get out of the ICU. So every day you go see the patient um, in the ICU, think about their needs, their most basic needs. If and not all of them are going to be on ventilators, but a significant portion of them is going to be on a ventilator. So how do I get them off the ventilator? And it helps to actually subscribe to the Society of Critical Care Medicine. Um, Actually, ICU is the one exception to the rule I shared with you guys about preparing, not preparing beforehand, because if time goes back, yes, I would have went to that website and did a little bit more reading. And if you're gonna read anything in that website, Society of Critical Care Medicine, I encourage you to read about ventilation settings, something that actually all of us need to brush up on every once in a while. Um, all the respiratory supplementation methods, how to escalate, de-escalate, something that will knock the socks out of your attending if you actually come up with it is knowing the parameters that the patient needs to meet to get off of the ventilator. So, for example, they do something called ventilator or sedation holiday every day. They take the patient off of the sedation and they see how they do on the ventilation on their own, to see if they can get extubated, because that's a huge component of being in the ICU. But being in the ICU, yes, to summarize, read up on your patients, spend time thinking about all their needs. And if you have time, I would invest a little bit of reading on the Society of Critical Care Medicine website.
Okay, so we know about the ventilator setting, ventilator parameters, and that's how we will impress our attendings in the
Right.
ICU.
Right.
That's great. Thank you very much. Well, thank you very much, Dr. Alani, for this amazing session. It was really helpful. You helped us a lot, and hopefully it will be easy rotation, easy internship for everyone. And wish you all a very good luck.
Thank you,
Thank
Dr.
you very
Al-Judi.
much.
Thank you, everyone.
Thank you, guys. Thank you, Dr. Alani, for giving this great talk. We really appreciate your time and consideration and your willingness to give back to the community. Thank you guys for attending, and I'll keep you posted about the next webinar to complete this series of how to be a good intern and resident in the future. Thank you very much. Have a wonderful day.